Hello and thank you for joining in on today's training. Heart & Solutions is a proud provider of CE-eligible trainings for our counseling community. This training may be eligible for continuing education credit hours through either the National Board for Certified Counselors, provider number 7376, or the Association of Play Therapy, provider number 21-645. To obtain CE hours for today's training, be sure to follow the steps in the description below to find and take your quiz.
Good morning. We are very excited to be back with another live webinar through You Need a Training. And today's training is presented by Amanda Hardy, who owns Meadowlark Clinic in Des Moines, Iowa. So for those of you that are joining us, you are here today to talk about supporting individuals as they transition to parenthood. And so over our time together today, we're going to have an opportunity to learn from Amanda about how to increase your skills for supporting families and individuals as they transition to parenthood. And to do that, we'll dive into the world of perinatal mood and anxiety disorders, as well as trauma and loss relating to conception, pregnancy, birth, and early parenting. We'll also have some time today to talk about and examine the role of American society and culture in shaping the perinatal experiences. And to do all of that, like I said, today's training is brought to us by Amanda Hardy. And Amanda, thank you so much for being here. For those that maybe haven't listened to our podcast episode yet, there are so many wonderful things to say about Amanda. But Amanda is a mental health counselor. She's duly licensed in Iowa and Illinois. She's also certified in perinatal mental health. Amanda began working in the mental health field in 2005 after completing her master's in psychological counseling from Monmouth University in West Long Branch, New Jersey. From 2009 until 2011, she took some leave from direct care as a therapist to re-enter graduate school and work towards a PhD in human development and family studies from Iowa State University. Amanda's doctoral studies and postgraduate work focus on childbirth, child development, parenting, and the intersectionality of these three. She has also been a birth doula and childbirth educator. For more than a decade, she has worked with local, national, and international birth and human rights advocacy organizations, promoting improvement to our maternity care system. In 2022, Amanda left her faculty position as a teaching professor at Iowa State University to focus on her mental health practice full-time. Amanda has extensive training in perinatal mental health and birth trauma, including EMDR. Her training programs have included Postpartum Support International, Seleni, Birth and Trauma Support Center, and Center for Creative Mindfulness. Amanda is also the author of Dear Mama, You Matter, honest talk about the transition to motherhood. So when I say that we have an expert at our disposal today, I mean it. And Amanda, thank you so much for being here and helping guide us through these really important conversations about that transition to parenthood.
Well, thank you so much for having me. It's an honor. Yeah. Okay, here, just kind of what I'm going to cover here. Like I'm going to cover this topic a little bit. I am going to hit on, obviously, perinatal mood and anxiety disorders, although when I approach this topic, I like to think about the transition to parenthood, not just as pathology. And so while that's obviously super important, and I know that, clinicians that are viewing this want to know about that, I also just want us to be able to meet clients where they are just in the normal, heart of parenthood. So while I am going to cover that, that's not the main focus. Going to talk about this concept of matrescence, some of the key challenges that we're seeing, modern parents facing, and then some ideas for, supporting folks through that. I do want to talk for just a minute, about that. I do use gendered language a lot. I will say women, mother, mom, but I think it's really important to recognize the diverse ways that people experiencing parenting and family structures. I know a lot of the research focuses on cisgendered women and men and heterosexual, relationships. but these, these experiences are not unique only to them. So partners and non-binary parents, may have very similar experiences and feelings, and, they are very valid and worthy of being included in these conversations. You'll hear that I really do try to use the gender neutral parenting language, but, I do want to just acknowledge that I do sometimes, dominate with terms like women, mother, and mom. So just note that if I'm not saying it, the others are, other ways of parenting are also absolutely included. So, okay, so this is kind of the what we call PMADS, perinatal mood and anxiety disorders. This is the kind of overview. So many of us have probably heard about postpartum depression. A lot of times we'll hear folks too, it doesn't matter what people call things, right? But they'll say like, oh, I had the postpartum, and kind of clinically, I was like, well, everybody has a postpartum, but they're often referring to, postpartum depression. And for decades, really, that was the only thing that we really used. But in more recently, we've been looking at, a broader scope. So we call it perinatal mood and anxiety disorders, or PMADS. In most of these, as we know, I am sure none of you are surprised to find out, right? The DSM is often like kind of a little behind on what we, that's a process that takes time, and, kind of what we're seeing in our practices and what's kind of happening, even with the research, it takes really some time to do some of those updates. So while there is one CPT code for postpartum depression, I think it's F53.3 or something, but really typically what we're doing is using, it really is major depressive disorder with peripartum onset is how it would be coded. So as far as like kind of from that perspective, as what are we diagnosing, again, with kind of that pathology lens. But so yeah, some of the key ones that are covered here in perinatal mood and anxiety disorder. So we have depression, and so, adjustment disorder is really a key one that we see, because I mean, this period is a definition of why we use adjustment disorder, a transition. So we might see adjustment disorder with depressed mood. We would also maybe see adjustment disorder with anxiety or depressed mood, which you can see later there. Anxiety, I'm going to talk on the next slide about prevalence. Anxiety, like panic disorders, I have a lot of fun with how many people are like, oh, I've been anxious my whole life and I didn't know it. And becoming a parent just like shines a spotlight on that. And so a lot of folks, when we kind of dig a little deeper, are like, oh, these behaviors aren't new. They're just maybe amplified, or again, just highlighted because of the perinatal period. So obsessive compulsive disorder, also can be present there. PTSD, birth trauma, again, I'll talk about prevalence rates on the next slide. Bipolar disorder, 1 or 2, and then obviously psychosis. So just quick note, like a lot of ways that we diagnose, any of these things, not in the, perinatal period, we're looking at some of those key things like the severity, duration, and obviously like any indications of, threat to the, the parent, the baby, others, to when we really see when are we getting into like increasing clinical concerns. So, but generally, symptoms are lasting longer than 2 days and past 2 weeks, for sure. Again, that's not too uncommon when we're looking at any type of a mental health condition. So not necessarily too much difference there.
Really quickly, as you talk about kind of some of that potential for anxiety disorders to sort of really surface during that time, are there certain symptoms or behaviors that you're really looking for, or that tend to be kind of most commonly displayed that kind of pique that concern or curiosity?
Yeah. So, and I will say this is good for this slide too, kind of looking at the prevalence rates. And you can see right here that, depression and anxiety, and kind of depending on which studies we look at, in some cases, anxiety is more than depression, more prevalent, either way. And as we know too, right, those two are kind of like best friends often, like co-occurring. So, but I would say I am seeing more and more anxiety. I think anxiety has been kind of like this sleeping dragon for probably a very, very long time. And like we're going to talk about later in this presentation, when we don't have the language for things and all we're looking at is postpartum depression. And so we weren't doing the studies and we weren't naming it and we weren't looking at it. So I am just very confident that anxiety is going to be the dominant one here in years to come, for sure. Let's see. So kind of symptoms, so I always talk to folks that like worry kind of comes with the job, right? Like you have a very needy, dependent being that, that has been handed to you and you've been told to, go home. So worry comes with the job, but, like with anxiety, not out of peripartum, it is, or perinatal, when is it interfering with daily functioning, right? When can I'm not able to get my work done. A big one is not sleeping, right? Because we're getting up and we're doing checking behaviors. We're checking on the baby constantly. Or a common one also is like, we spent hours going down a Google rabbit hole and we didn't get any sleep. Things like that. So when it's really, because lack of sleep is a huge contributing factor to any mental health condition. And so a huge risk factor with this population, right? Because our sleep cycles are off. And so the key is like, if you're able to sleep, like, again, not the sometimes sleep when the baby sleeps, but especially like at night, if you are able to go to sleep and good sleep, but if you are interrupting that process even more because of some of these anxious and intrusive thoughts, then that's when we're starting to see that could be interfering. And again, we can kind of jump into that OCD. A lot of times we have kind of that pure OCD, where it's just like those obsessive thoughts or the intrusive thoughts, rumination. And again, people don't think that OCD is anything other than trying to be clean. And we know very well that it's not. And so, that would show up here too, for sure. And I can go a little deeper on that if that.
Yeah, I mean, I think that's really interesting, right? To think about kind of how you phrase that of like the pure OCD, right? Yeah. And finding and trying to kind of conceptualize and help others understand that distinction between, of course, you're going to worry or you're going to be fearful or think, something might happen. But what that really looks like when we're working with clients, right? And thinking, okay, but you've expressed this, or you're saying this, and now it's more than just kind of expected concerns.
Yeah. I mean, definitely, just getting caught up in that spiral, and can't be, kind of settled or resolved. I talk about anxiety seems to always start with like, well, what if, or well, what about, and when we can't cope in like adaptive ways, to be able to stay regulated, even with a worry. Yeah. Okay, so just kind of quick overview of, of like prevalence. And again, a lot of this is to help you as what you are seeing, because you will be seeing perinatal people, in your practices, even if that is not your target population that you're going to be working with. What we call the baby blues is very normal. I mean, arguably, really, I think we could almost push this to 100%. But, and what that is that it's typically about 2 weeks postpartum. So 2 weeks after birth. And I do want to kind of pause and say, this is where I talk about different family structures and stuff. Like this is also can present in like adoptive families or situations like that. And again, a lot of that baby blues is maybe what we would say is that typical like adjustment period for sure. But yeah, this is where we've got a lot of like those hormones are just like crashing out, and then, even if you're going to breastfeed or not, whatever, the body is still, if you gave birth, is still queuing up, those lactation hormones. So we've got a lot going on there. These are obviously just like we're getting to know someone new and we're tired. Our body is physically recovering from having had a pregnancy and given birth, whichever way you gave birth. So this is definitely that key adjustment period, baby blues. So very normal and expected. And that doesn't mean that we don't still need support, through that. It is hard, but very, very common to feel very kind of not yourself. I talk a lot about the postpartum period is just, it's inherently foggy. Everybody, I would say it's universal that you're going to experience fog. What varies between people is like kind of the density of that fog. And then, like how long does it last? But what we call the fourth trimester is really like that 3 to 4 months after birth. And that's typically throughout that 3 to 4 months with, that fog tends to get thinner. We can see it tends to kind of lift throughout that time. So if you think about it in that way, that's baby blues period at that very beginning, it's just like, woo, we cannot see far in front of us because that fog is so thick. Another one that I really want to normalize is intrusive thoughts. And this is tough, right? Because none of us, we don't like that. That is not a good feeling. And as you can see here, like around 50% of those intrusive thoughts are specifically about like harming their baby or harm coming to their baby. Those are very uncomfortable experiences to have. And so things like that are a big one, again, that are going to send people maybe into getting some help because of those disturbing thoughts. And I guess where I really want to talk to clinicians is just because somebody is having those thoughts, right? When we're talking like, ego dystonic, right? These are uncomfortable thoughts. And I'll talk more about psychosis, but right, that is not the same thing as psychosis. This is very normal. There's a great book by Karen Kleinman. I think it's in my at the end called Good Moms Have Scary Thoughts. Great way to kind of, again, just normalize how common this is. And again, it doesn't mean we can't support people with that, looking at that kind of from that anxiety, but very common to have some of that.
When we think about those intrusive thoughts, right, and normalizing how common those are, as a provider, are there concerns or considerations, maybe is a better word, between a distinction of bad things happening to my baby versus the thoughts of me doing harm to my baby?
Yep. I mean, and I would say just kind of the easiest way that I can distinguish this is if you are identifying these as like thoughts and you are disturbed by them, right? Like if they are uncomfortable to you, and you are very aware of them as a thought, and we can key in on that. I mean, right there is a key indicator that we are having, anxiety or intrusive thoughts, and that we're not in psychosis. And it's very important too, when we look at these prevalence rates, this is not the progression. You don't go from having intrusive thoughts to psychosis, so this isn't in first this, then this, then this in increasing severity. That's not how that happens. And so that's also helpful, and again, it doesn't mean it's not kind of cause for alarm, but what is typically more cause for alarm with folks that are having intrusive thoughts, especially if they are about harming the baby, here is where parents will start not engaging with the baby, right? They will stop being, I don't want to feed the baby or hold the baby. I'm going to smother the baby. So I have to have my partner hold the baby. I can't, I'm going to hurt the baby. And, so there we have interruption of daily life, interruption of caregiving, and so that's, more what we see. And psychosis, I'll talk about here in a second, looks and presents differently. So yeah, if we are able to very clearly identify those and be like disturbed by those, I'm okay with that. We can work with that,
That helps.
Yeah. And just really quick while we're on it too, I mean, probably the number one intervention for that at least that kind of starting point is, thoughts are not facts, right? And we're identifying, yep, that's a scary thought. and thoughts are not facts, which I'm sure, we could talk about more, but I'm guessing a lot of folks have some way that you might typically be working with these types of intrusive thoughts with other clients, and it would apply here too. And I find that to be very helpful, a helpful mantra that seems to work to at least dial it down just a tiny bit for folks. Let's see. So like I said, depression and anxiety, this is the most common complication of childbirth. So it's a big deal. It's a big need. It's why I'm in this kind of niche area. I love working with this population. I don't think that there's, kind of enough of that. And so to be aware. I think, let's see, some distinguishing characteristics about like depression. Definitely, again, we're seeing a lot of the same things we would with major depressive disorder, not in perinatum, right? But we have flat affect. You are sleeping like too much, right? Like, so we're not talking about taking good naps and getting good rests. It's kind of we're checking out. We're sleeping all the time, very, very low motivation. We are going through the motions. And this is where it is tricky, because we do have a group of people that are inherently a lot more tired. We are feeling, we're going to talk about this more, but feeling a lot less capable to go and engage in their lives in the way that they once felt that they would. Throw in a little bit of anxiety about something happening when I'm out in public. There's a little bit of, and it's a big challenge to kind of identify, do we really have clinical, depression going on here? Are we still kind of that adjustment with depression? Let's see. But yeah, so some of that we call it kind of like mechanical infant caring. You're going through the motions, you're getting everything done. But there's you're not feeling like you're connecting, and you're not kind of taking joy and delight in your baby, which I very much want to clarify and bust that myth a little bit, that when that baby is born, you just feel bliss. It is so common to not feel that way. I would actually say folks reporting that they felt that way is rarer than folks feeling almost just kind of a little bit of a deer in the headlights, whoa, okay, this happened, there's this baby, and a little bit of that shock, and everything's just kind of hitting you, but again, if you're thinking back to that 4th trimester and that fog, that should be coming, and so again, if we're 6 weeks postpartum, we're 8 weeks postpartum, and you're still just kind of feeling numb, right? And feeling I'm not, excited about, my baby and stuff, then we might be in that category of depression. I think we kind of hit on anxiety presentation. I'm trying to think if there's anything. Colleen, is there anything, questions there, or maybe that I didn't hit on?
No, I think that's been really, really helpful, right? Of kind of giving space to what that means, right? And where those kind of expected feelings are versus that kind of differential to more of a concern, and helping clinicians recognize, again, just kind of when are we kind of crossing that threshold. And I like okay, let's keep in mind, right? What that kind of fog space looks like, and are we reaching a point after that where we are coming out of some of that, or are we still there? I think all of that's been really helpful, especially for those that aren't doing this all of the time with clients. But I know you mentioned at the start, right? Whether someone is seeking to work with clients who are transitioning to parenthood, they're going to have clients on their caseload that are transitioning to parenthood. So very, good to kind of have that overview of what's what. And
and I think that this is a good, I'm kind of, something you said there reminding me to highlight, this is where as providers, where we of course never want to do any harm. But I'm glad that, attending trainings like this and others to know, again, the normalcy of the challenges of this transition. And again, I hope that fog analogy is kind of helpful, because it can be really hard to be in what's kind of a normal struggle. Again, still a struggle, but kind of what would be considered pretty normative. And again, so meaning a lot of your peers are experiencing these same things, and where we could meet somebody with kind of some of that validation normalizing and just put support around them in that way, versus when then we get labeled with postpartum depression, and how much I hope that maybe you can hear how much that can be very unintentionally harmful, that can maybe kind of like tank someone out, just kind of drop them out when they're in what might be arguably pretty normal. And again, the lines around this are fuzzy, but I hope, things like this and these conversations help to just be maybe cautious with that. I would say, especially in that fourth trimester, because it is such it's just the ultimate transition. Yeah. Adjustment. Let's see, OCD. Again, we'll sometimes see folks that I would say, I don't know about a population not outside of perinatal with OCD, just that I don't work with that group specifically, but I do feel like we get a lot of the rumination, and what kind of like that pure O, and just, like we're down the Google rabbit holes we're talking hours, we're staying up at night, and we're playing scenarios, and we're, so a lot of that is not necessarily coming out in those compulsions, in those behaviors, but we are suffering up here, and we cannot stop that. So that's not uncommon to see some of that. And then again, some of the typical OCDs, typically these are around like usually health and safety of baby. A lot of folks that'll come up health anxiety. If we've had maybe some trauma during the birth or the pregnancy. But yeah, health stuff for baby or self, right? Like suddenly what happens to me matters a lot more than it did. And so sometimes that can get, maybe into some OCD. But yeah, we do see a lot of some of that typical stuff like, contamination, so we do see, the cleaning of the baby bottles, 3 multiple times. I can't put the baby down on the rug because if somebody walked in with their shoes, there'll be, things tracked on, so again, it's disrupting life, and I'm spending a lot of time in my day and maybe engaging in some types of these compulsions, or like you say, just kind of like the rumination. Let's see. So PTSD, 3 to 9%. And here's what's I think important to notice. Around about 45%, upwards of half of birthing people in America experienced birth trauma. That's a big number.
That is not a number I would have guessed, right? Had you played a game with us at this training, I don't know if I would have guessed that, right? And with that, is that, and maybe I'm putting you on the spot here, right? Like, how is that defined? Is that a report? Are there certain kind of additional pieces to be aware of with that?
I want to say off the top of my head, one of the key criteria is like the threat of harm to self or baby. Again, kind of, not unsimilar to other types of trauma. So whether like real or perceived, the belief of harm, and then like that ability to overcome it. And we have to recognize that like how vulnerable we are when we are birthing. And then again, we're not in this talk, but let's get into all the history that people bring to that and all of those experiences and just how vulnerable we are. And so I think that the potential for, this was in my dissertation, right? So I could really get into this, but like, our culture, we thrive on fear, we're very fear-based, and that is definitely true in childbirth. So, just like the pressure cooker on that, I think is high. And, another thing that happens with people reporting, even just let's call them negative birth experiences, a huge one is just the way that you were spoken to, the way that the communication was between staff and the birthing person or partner. And when I do these talks to doctors and nurses, I'm just like, that's such an area where, feeling like you are treating people like fully consenting adults who are, autonomous and want to be involved in their care and what is happening to them. And it's the 20th birth you've seen that day, but it's their only one. So feeling like you were not treated well is a common report. Again, not an indicator alone of a birth trauma, but a high rates of that. So sometimes folks need to come in and just process that, and again, so holding the space and listening for them with that. And I will tell you right now, this is not on another slide and I should have put it in bold, but like, please remove the phrase, but you have a healthy baby from your vocabulary. Just erase it, delete it from your practices, from your social life. Just never say it again. I hope you've never have. And if you have, just let's just not do it again. And actually that's kind of where the title of my book came from, is you have a healthy baby. That's all that matters, right? So invalidating, so dismissive. And so you matter too, how you went through these experiences, how you're transitioning matters too. So that's how I got Dear Mama, You Matter. So, so a lot of folks need to process that. And we can hold that, we can be containment for that. But again, know how normal that is. But what I really want to connect there too is that we're really only seeing like the development of actual, truly PTSD in, 3 to 9% of cases. So even though we have the high rates of, maybe traumatic experiences, that doesn't mean folks always develop PTSD. And so again, the odds that you will encounter someone that has kind of some varying degree of what I would call a difficult birth, traumatic birth, very likely. And again, we can throw in here some other contributing factors, especially if things were an emergency. Obviously, things that became an emergency, we're going to see increased rates of that. NICU family, so that stands for neonatal intensive care unit. If someone had a NICU stay, I'm even talking they had the easiest NICU stay, they were in and out in 2 days. 60%, I think 60% of NICU families have like PMADs, and definitely in this category here. And again, a lot likely to develop that like OCD and anxiety, which again, same kind of category there. A lot of that, especially NICU, right? Everything is being monitored. Well, one, we have some really serious health risks to baby. But also we have, even if baby comes out of there and everything is fine and we're home, everything had been monitored, like literally like how much they were eating, how much output, what their O2s were all. And so that the only way my baby is safe is if I know all of this data. And then they're just like, well, just go home. And what? So you can kind of see how that could contribute to that. But so just know those are big risk factors for PTSD. Right there. And again, in partners too, emergency situations. I don't think I hit this on there, but 10%, around 10% of partners can develop a PMADs too. And one of the number one factors to a partner getting PMAD is that the birthing person has a PMAD. So talking about kind of primary prevention, right? Like if we can treat that, we're treating the whole system. So okay, psychosis. I know that this is a big one people are obviously very worried about because, and rightfully so, because psychosis is very serious. Psychosis is, we are going to the emergency room. This is like a hospital, admission in most cases, immediate, urgent situations. And here's where, again, psychosis, this is not just like a progression. You don't go from like having depression and anxiety and OCD to psychosis. They're two different tracks. And again, just like, talking to clinicians here in other situations, that's not the way that these things go. Key things with psychosis, again, even outside of perinatal, right? Like, that it's that break with reality, right? We've got loss of sense of time and place. We've got confusion. Sometimes we'll see folks with almost kind of some of that like mania-like energy, so not sleeping. Often we're having some of those, maybe some hallucinations. We are talking about, that fog and confusion that is extreme, and often kind of somewhat sudden, right? Again, we're not dealing with like, okay, we've been having some of the fog and some of the normal. We're talking like we see a shift. And I always talk about psychosis is more often than not, the person that's experiencing it doesn't know that they're experiencing it. Right. And so with all these other ones on this list, somebody saying, I'm not myself, I don't feel right. A person with psychosis, sometimes, of course, but often it is the partner or other caregivers that are hearing and seeing these things. And so I'm always like, those are the folks that need some of the education on this, and of course, as well as we do. So, what didn't I hit on there that might be a question?
No, I think just that distinction, right? Going back to where we were talking about the intrusive thoughts, right? And the client's awareness of, like, I don't like this thought. This thought doesn't feel good. This is not something I want to be thinking. And for those that are rewatching this webinar later who maybe aren't zoomed in, right? That psychosis is 0.1 to 0.2%.
Right. Yes.
Right. Like we're talking minuscule. And so that severity and that importance, but recognizing a majority of clients that we are going to encounter are not going to experience that. But yeah, I think for me, kind of hearing that distinction of like, can I recognize that this thought is not what I want to be having versus not having that awareness. So,
I think it's hard when you hear somebody come in that says, I'm a bad mom. I think I'm going to hurt my kids. Okay, hold on. Let's pick that apart, right? Where is that coming from? How can we distinguish that? Again, that kind of like that ego dystonic. So, and I want to say, just to give you an idea, so I've been working exclusively with the perinatal population in, a clinical mental health setting since 2017. So what is that? Is that 7 years? Something like that. Man, where does the time go? And I think I have seen 3 cases. And I think if I'm thinking off the top of my head, I think one of those, we really in the end decided it was bipolar, and, was having, a manic episode. So just to give you that, and so it's rare, I would say that I would be one that would see more than the average. And in all of those years, I think I've seen 3. So, and a lot of times they're coming to me like after it's happened. I'm not even the one identifying it, and again, there's some information at the end, but, having some contacts for someone that you can do a consult with, so we're not hearing somebody say, I think I'm a bad mom, I'm going to hurt my baby. And we're kind of in those intrusive thoughts and anxiety, and we're sending them to the ER. So, and that's, again, this is why we want to have emergency contacts, right? Do we need more context here, and how are we going to do that planning with somebody to say, I got to get some more details. And I'm going to say, again, in a lot of those cases too, it is that partner or other support persons that are alerting, saying something is not okay, versus I'm worried about this person and I want to see them get help for these things, versus like something changed here. Like, it seems to be kind of more marked. And then, bipolar prevalence rates are kind of inconsistent, and it can often be misdiagnosed. One of the biggest things about bipolar is more often than not, they had bipolar beforehand. That's the number one thing. You typically don't develop bipolar after, that you didn't have before, but again, sometimes people didn't know things, that they maybe had some of that and it had gone undiagnosed, but rates of that, again, relatively like lower, but we definitely see that. And usually we know those risk factors. So, man, I spent a lot of time on that slide. Woo.
Yeah. I mean, with that too, though, like with that bipolar situation, is there, could a client maybe experience greater shifts or more marked
symptoms
that may bring that to light?
Yes. So thank you. Yeah. So definitely. So if we have somebody that like knew they had bipolar, right? Hopefully, they are in a space where they are able to be working with providers and they're figuring out what to do through that pregnancy, and then kind of preparing for, what's maybe, and so they've got folks like myself and others like kind of on board for the postpartum to try to help make sure we're managing and staying on top of that. Cause we do have to sometimes mess with medications or what has been working. And again, some of these other just big changes and shift, lack of sleep, again, huge factor in so many of these. And especially here again, so trying to being prepared, but especially if we had somebody that didn't previously have that diagnosis, yes, we might definitely see some of those symptoms come up. And, hopefully if we've got good history and good kind of consultation and all of that to be able to, identify that and get folks on the right supports and stuff. Yeah. Yeah. Like I think I kind of hit on that. There's a good resources there. Postpartum, that's Postpartum Supports International's website. Great fact sheets and stuff for clinicians, for clients, about, kind of some of these things and what to look for in more detail, obviously, than what I've shared here. So, okay. We can always circle back to any more of this too. Okay. So shifting a little bit more into the topic that I want to spend a little time on. Again, I understand that knowing the clinical details are so important, but I think the truth is, and again, what I want to validate, what I want to normalize, what I want to give language and conversation to is that even without something meeting full like clinical criteria, this is a challenging time. It is hard, and hard is normal, and we are just worthy of support during this time, even if it doesn't meet full, kind of clinical criteria. So I want to talk about this word matrescence. And here you can see kind of at the bottom of my slide here, this is like the word maternal plus adolescence. So matrescence. This word comes from anthropology. It was originally used by Dr. Raphael in the 70s to describe the transition to motherhood, very much like adolescence. So just like we have that word adolescence, we know what to expect during those, essentially kind of those teen years, the preteen to young adult years, right? It is all about just transition, huge transitions. It's about hormones. It's about identity. And it is change, and it is big. And I think that what is so important is that because we have that language, right? Like, so language shapes our perception. It shapes the way that then we normalize and meet ourselves in these moments. And I think that we don't do this for motherhood, or parenthood. We sometimes, I think, kind of culturally talk about this as just like, yeah, you're having a baby. It's just like an accessory that'll just fit into this little corner of your life called, the nursery. And yeah, like we have a car seat now, but no, it just takes over everything, and just shifts us completely. And that is a big deal, just like with adolescence. And I like to say, and I'll talk about this a little bit more, right? But we talk so much about getting back to your body, getting back to your activities, getting back to yourself. And what I'm aiming to do here is helping folks realize, with kindness and compassion, that there's no going back, right? And there never was to anything. Like, had I not had kids, I'm still not going to be 25-year-old me. No. And that we are ever evolving, lifespan development, right? And this one is just bold and often very big, and it can be very, very rattling because we have this kind of concept of, I've arrived at this kind of peak of adulthood, and that is where I will stay. No, and that's hard, or can be. And I like to say, we don't ever look at the 18-year-old and go, when are you getting back to your 13-year-old self? Like, that's ludicrous. Like, we don't do that. And I think that mothers and parents are owed that same courtesy to not tell them that. Right, it just built into that as kind of that something must be wrong if you're not back, so again, kind of some of those cues that just say, uh-oh, why am I not back? I'm supposed to be back. No. So let's change our language and normalize some of that. So talking about the transition, so you all have probably seen this, whether you use it in your practices or you remember it from grad school, right? But it's like the life change, kind of like the life stressor index. And so this is non-clinical. This is me. This is just my experience. This is not empirical research here. But I'm just highlighting how many of the things on this list might we be able to apply, kind of depending on the case. And I'm putting injury or illness mostly just because the way that perinatal defines like pre-conception through like, conception, pregnancy, the birth, and then really the year after, so that's like a 2-year period of people's life. And then in a lot of cases, people are maybe having more, so we're talking about this, and arguably we're always postpartum, but kind of technically we think about that as being a year after, but it's also the time before. And so kind of injury or illness, even if you're having like an uncomplicated, a very healthy, like pregnancy or conception journey, even at birth, like it's still just a change in like your abilities. And so I'm just arguing that it could be akin to some of that. And again, just the recovery that it takes for our bodies, which again, we do not talk about culturally. The recovery time for a body, you grew a human. It's a whole being. What? So here, so change in health of a family member. Again, we could see how that might apply, even just in their abilities to be, the way that we shared duties around the house and what we did for our jobs, and that's not even throwing in actual complications. Obviously, pregnancy itself is on there. Sex difficulties, huge. Again, it could do a whole separate talk on intimacy and sex postpartum, or perinatal, gaining a new family member, change in finances, number of arguments with your spouse, maybe not all, but not uncommon for that to happen. Responsibilities at work. Maybe you've changed how you're doing work, or even just being on a leave at some time for either person. Again, things like, personal health, how's that changing some of that? How you're able to go and participate in, recreational activities, social activities, sleeping habits. So again, even if somebody isn't checking all of these that I kind of offered up, clearly, we're hitting a few there. So, basically, we're just saying that this is a time of high stress. This is really what I'm trying to highlight. And maybe it was already obvious, but I just thought this kind of validated, how stressful these changes and this transition is. So, okay. So we're going to talk a little bit more about this, these transitions. So, like I mentioned with matrescence, it's a change to identity, and it is not about, just like assuming this new role, right? I got a promotion at work and now I have this new title. It is about oneself and this redefinition of self. And I always like to say, because that's such an easy task anyway, please interpret sarcasm, and now we're holding this extremely dependent, the neediest of little beings who is 100% dependent on us while we're trying to redefine ourselves. So walk in the park, right? No problem. So it's just challenging. And like I said, just that approach of like, how are we ever, we are ever evolving, and how does helping our clients, with that mindset and, change and evolution and here to the next part here, right? That means loss. Change means loss, even positive change, like a marriage and somebody's joining the family, like a baby and a new family member, their change comes with losses, and we want to say like, oh, it has to just be this one way. It's good. I wanted this. Why do I not feel so good? Because it's hard, because it is very hard. And hard, to my little sidebar here, while hard is so normal, that doesn't make it any less hard, and so really, if there is a gift or a tool that I could give you as fellow clinicians who are going to meet people in the perinatal period, that validation for the hard is so powerful. And just to say, I see you, like, it's hard, and that is so normal. And I'm here for it. Huge. The amount of times that I have had people, kind of come into my office and just kind of go, oh, just you feel that just in their bodies. It's like, it just kind of that exhale of, oh my gosh, thank you for telling me that this is normal and seeing me and that it's okay that I'm struggling. I'm not broken. I'm not doing something wrong. So like I said, some of the losses, it is really common to feel, lost and unrecognizable, and especially grieving for that pre-parent, pre-motherhood self. And again, this is where I do think it gets tricky, because as clinicians, I think we're quick to go, I'm lost. I don't feel like myself. I'm in this space. depression, right? And that's where I kind of go, pull back just a little bit and kind of, again, I don't want to say underdiagnose folks, but I do just want to kind of be like the baseline is hard. The bar is set at hard. And so think about some of these things coming when you have that lens, when you're hearing these things. So some of these big losses, and I talk a lot about this, but I do think using a grief lens, I find to be very helpful. And that is hard. People don't want to think about grieving stuff while I've just welcomed this baby, especially like I wanted this baby so much. This baby is this manifestation of my love for my partner come to physical form. I don't want to grieve. Yeah, and so I think, again, this is where we can show up, sit with them in that space, hold that space, validate, and help, walk them through some of this. And so, yeah, some of the things, right, like loss of freedom, self-identity, loss of social community things, just to kind of, name a few. Let's see. Yeah, and I think another note here on my notes, like talking about those changes, right? It's physical, it's emotional, it's social, it is not just this one thing that is kind of happening just inside me, right? That like I'm evolving. It is the way that I interact with the world. It is the way that I feel in my body. It is the way that I feel about myself. Yeah. And again, I kind of just put here on my notes, this is just, I feel like such a classic example of why that diagnosis of adjustment disorder that we have it, and I feel like these, again, in the normal, and again, we looked at prevalence, absolutely, we passed the normal, but yeah. Then yeah, just because these experiences might not be pathological, some might, doesn't mean that they're not valid challenges and worthy of our support and validation. So that's the drum that I will beat a lot. Okay, so how do we help manage some of these expectations? Again, how do we come in here as providers, and again, folks that are interacting in the world too. So whether they're your clients or not. Like I said, I think I kind of hit on this heavy emphasis on getting back to this pre-baby life. We love to talk about women's bodies and birthing people's bodies. Again, things you could probably never do. Just never comment on another person's body, just ever again. I don't think we would be harmed to do so. But yeah, these right here, just that guilt, that overwhelm, that is probably one of the most common things that I hear perinatal folks talk about. It's just like, I'm just so overwhelmed. And a huge piece of this that I don't even dive into in this presentation is the mental load, right? And in a lot of cases here, especially in that newborn fourth trimester, like the physical load, right? We are not sleeping. We are doing feeding in whatever way we are doing feeding. And whether that is, from your body or preparing, that is effort, and that is thinking, and that is calculating math of formula and ounces and diaper, the mental load is exhausting. And again, physical load, on top of sleep disruption, work-life disruption. Yeah. And then again, when these conversations, these social constructions are, you should, keyword there that's going to be an anxiety trigger, right? You should be somewhere else, or you should feel some different way. I'm so blissed out. I'm just in love with my baby, and you're like, I do not feel that way. Something's wrong with me, so cue some of those. So being aware of that. I really, again, around society, man, I would like to say that like, hyper independence is America's toxic trait. Like we, do so much of, I can do it myself. I am an island. We are not a collectivist society. We are an individualistic society. And I don't think I hit on this in this presentation, but like the pandemic only amplified that. And wherever, it's 2024 when this is being recorded. And I mean, the impacts of like literal isolation. And then, again, so many people were having babies during that time. And, so that I have to do it myself, and to need help is wrong, bad, I'm broken. Again, I should be independent, right? I mean, that how many of us, if we even say, how do we want to raise our kids to be, independent adults that can do things, you hear it, right? That's so common, and independence. And so kind of the counter of that is like, don't need others, don't need help, do it alone. If you're doing it right, if you're doing it good, you shouldn't need other people. One, I think that's so wrong. And obviously I can critique a cultural critique there, but like, especially when we're raising tiny humans, we need each other. And the thing is, when I say it's our toxic trait, like that is counter to how our brains are wired, right? Humans are wired for social connection. Like we need each other. And so I talk to my postpartum or my perinatal folks, and I'm saying your brain and your whole body is craving that, right? Like everything is telling you, like, I feel like I need people. That feels like that would feel good to me. And yet then it's not available. Or we're getting kind of this message from society that like you really shouldn't, so there's this there's dissonance, and this kind of tension between that. And again, where you can see how that can cue people to be like, what's wrong with me? And yeah.
Yeah, that cognitive dissonance, right? And I think it's amplified by those societal expectations, right? And thinking about, even the like, well, you've got to take care of yourself, but if somebody else is taking care of your child, right, then you're wrong. But if you don't take care of yourself, then you're not doing it right? And that like you talked about, that strive for independence of like, I have to prove I can do it all, like, and how much pressure that is. And thinking back to where we started today, like, so then if we do have a parent who is experiencing some of those PMADs, right, on top of like, now I have this internal thought that I can't ask for help or I'm failing even more. What an uncomfortable place to be.
Yeah, for sure. Gosh, you said something there that I kind of wanted to jump on, but well, and it's such that cognitive dissonance, right? That dissonance is so internalized. Like I think very few of us sit down and are like, yes, I think that this strive for independence is causing me harm. No, these are, like I say, it's the drinking water that we've been that we've been swallowing our whole life. It's in our cells that this is how things should be. And if you're listening and not watching me, I'm making air quotes, right? How things should be, and yet at the same time, our neurobiology is saying, no, so just, so I do think, again, naming that, there's kind of some of that psychoeducation right there that you can do to say like, you are not wrong. And, let's get rid of that, and let's talk about that and kind of pick that apart by just identifying it. So let's see. I think we kind of hit on this identity development again, this reevaluation and adjustment of one's sense of self and how we navigate the world, not overnight. I think that that's a big thing too, and where I so much like to bring in that language of matrescence and use the parallel with adolescence, because arguably all of these folks that we're working with have gone through an adolescence, to say like, you didn't do that overnight. You didn't just turn a teenager and we're like, boom, now that's done. Puberty, cool, check. Years, and I want to say, again, there's kind of like some of that grief and some of that, like you might be sitting with folks, they're like, well, I don't like what you just said. Yep. Let's sit with that. Let's look at this. How do we do this nice and slow? How do we show up with self-compassion and grace and gentleness, to say, like, this is okay, that this is going to feel a little messy and we're going to navigate these kind of uncharted waters. Let's see. Okay, so we're getting more and more data about social media. I know I'm absolutely confident. One, you all have probably had your own experiences with it. You probably know some of the data that we're seeing about like teens. I know this has been on Capitol Hill and putting some of these limits on social media, and the truth is, I mean, that is great, but it does not stop with like having an impact negatively on just teens. And again, here is this crux, right? Because we are isolated and we're, home alone, maybe nursing a baby in the middle of the night, and we pick it up and we scroll a little bit and we feel a sense of connection. We feel like we are like with others and we're seeing others. And so in some ways that can be a really good thing. It can be kind of a touch point to the outside world if it is challenging to actually make those connections. And at the same time, it can be a huge source of social comparison, which again, just can breed, again, anxiety and depression, most I'm not like them. I'm not doing okay because I don't look like these curated images. And as much as people can intellectually know that, when we're sitting there and we're scrolling through that feed and we think it's not, in the same way, yeah. So it plays a role. We're getting more and more data on how much that can negatively impact us. So the biggest thing I talk to folks about is, rarely am I like, don't cold turkey it. Like, that's okay. There is some good there, but take note of how you feel when you're scrolling. And I like to talk a lot about, like, go ahead and curate your feed, hide some folks, unfollow some of those pages that maybe you had been following. If you watch that content or read that and you're just like, you feel ick, whatever that is, after that, you feel negative about yourself, then maybe take a pause from that. And when I say curate, that also means finding that type of content that feels like maybe those more real and authentic, and the stuff that doesn't make you feel good. In my morning scroll, even just today, because of course, even though I do not have young children anymore and I'm done birthing my babies because of the work I do, I'm in this so much. And I saw a mom saying that she was giving a real tour of her home. And it was like, here's the room that we don't use. It was a formal dining room. We don't use this dining room. And so it's our mail room. What, here's all the packages in the corner. And here's some kid's toy that was, and I'm like, follow those, if that makes you feel good, to be like, listen, everybody's got a pile of laundry sitting on a chair in a corner of their room. I promise you, and so the more that you find those people that feel good to you, that do not make you feel worse than anything else. And that was just one example. That content's out there. So curate that, look for that, yeah. And again, just, this is where, as from that clinical perspective, just showing up, and we can do this, how do we help people navigate guilt and shame? Again, so much of that is, I must be doing something wrong. I hear it so much. If this is hard, it must be wrong. Right. And I think that really trying to help, kind of dissect that, and again, deal with like that dissonance there. And no, it's just, we're going to baseline, this is hard, and you are normal. And again, I'm not talking, let's not do all of our clinical assessments, but helping people deal with that and that negative self-talk and going down those kind of negative spirals. So, and some of those things, like, yeah, just again, so we're normalizing, we're going to do, good psychoeducation, helping people identify some of those trigger words like should, what if, what about, I'm supposed to be, who says, I say that to my clients all the time, said who, whose voice is that? So I think we pick a lot, look at the social construction, right? What are the building blocks? Thoughts, Colleen, or anyone?
No, I mean, I think it's just, again, so helpful to think about and making some of those, kind of, intentional kind of check-ins too with clients, like what is that experience? Where are we at? Are we up in the middle of the night? I was talking with someone in my life, and they were like, well, when I had kids, 24-hour news had just been a thing, right? And so that was the first time we could actually sit up all night and watch something, right? And so the evolution from that to where we're at now with the world at our fingertips. And I was at a different training not too long ago, and they talked about with social media and like having the phone right next to the bed, right? And like moving that so that we can check in with ourselves before checking in with the rest of the world, right? And I like that in this concept too, of like, let's check in with ourselves as that parent and how we're assessing where we're at before we kind of go, what's everybody else doing and where's my comparison measurements today?
Yeah, absolutely.
I guess one other thing, Amanda, too, I was thinking about on the slide, right, is as a play therapist, right, I do a ton of work with young children and with adolescents. And one of the things we talk about constantly, especially with adolescent development, right, is, okay, hold on, let's take a step back. Let's look at what that early childhood experience was, because we're going to see potentially some developmental, delays or deterrents with that, right? And we're going to see some things that maybe are outside of the expected
Yeah.
norms. And I'm going, yes, right? Like, let's apply that concept to like, okay, like what has this life experience been, and will there be some additional complicated factors, right, with this developmental period? And that's probably a whole other training we could sit and do, right? But
I can't remember if I do get to this on another slide, but since well, one, like, thank you for all that perspective. So good. But I a lot of times I feel like this population, and especially because we are caring for children where there is kind of this sense of urgency, is there is some level of, definitely in that first bit, there's often a lot of like kind of solution focused, very here and now, almost kind of some crisis management stuff, and then I think that after we kind of get through that, we get to some stabilization. Then I think we're working more on this. Let's talk about some of this identity. Let's talk about some of these factors. But Colleen was mentioning at the beginning that I did a podcast with you guys last week, and most of these folks are not coming in. If they're coming in identifying something specifically in the perinatal period, they're not like, I want to talk about my relationship with my mother. That's typically not, it's, let's talk about what is happening to me right in the here and now. Literally, I need help tonight because I feel like I can't take care of my baby. So just a little bit of that, planting that seed, that often we're kind of meeting folks there. And then definitely, I think some of this identity isn't the thing we're going to do on day one, but just know for our own sake that that's like in there. Yeah. Well, and I think you were talking, so here's the challenges of modern motherhood. And you named this, right? The 24/7 news cycle, and information overload. So, and here's the thing, like, so information overload, and why these two things are separate. Information overload, like, so we did the studies and we learned about SIDS, right? And put kids back to sleep. Great information, and what that has also done is then, am I doing it right? And there's a right way now, and there's a wrong way. And so we're so good. We're glad that we have that, but it can also become a source of just like too much. And we have so many. Let me give another example, right? And I write about this in the book, but like, we're talking about which sunscreen is the non-toxic sunscreen, and do we feed organic versus the not organic? And I wanted to chest or breastfeed, and now I can't. And so now which formula and how, and should they really be eating? Right. And so all of these little, like, these decisions that are just daily all the time, because we have information, but it is also at our fingertips constantly, and it used to maybe be, your mom's, for better or worse, the moms and the aunties, or, and maybe your pediatrician and your kind of other little mom friends, and now it's the internet, which has a lot to say about everything. So like that decision fatigue, that mental load, that overwhelm is so real. And I think a lot of times, at least what I'm seeing, is like the stakes feel so high, because they are. And here I'm talking about SIDS, right? But then that also gets to apply to the sunscreen or which baby furniture I bought, because I heard that this baby furniture, it was made with this material, and and it is overwhelming, and if I don't make the right decision, I'm harming my baby, right? So there's some of those cognitive distortions in there, a lot of that kind of black and white thinking, and that can come into play. So I think being able to kind of unpack that, recognize that, talk to folks about that. And then the 24/7 news cycle being a little bit different is that this is what I kind of call like the big scaries in the world, that like we can't get away from it. And there's a lot of big scaries in the world. And again, like our news cycle feeds on, what is that word? The exciting, the enticing, they want the drama. And, and again, maybe even generations past, maybe even just 1 or 2 generations ago, it was like, you would only hear about some of this stuff. It was local. It was rare that you would get like this big international story about some big scary, and now it is constant, and it is in your pocket all the time, and so even on social media, when we're talking about watching the, kind of the mommy pages on social media, but I'm also talking about how, the news cycle comes into those spaces too, so these things are just, they are a lot. And yeah, other things that we are doing differently. We spend more time with our kids than generations past. We are also working more than generations past, and also more likely to be dual income working families, which is another bullet point there. So like, again, a little bit of a social construction, a little, around, when you're not, we used to do what's called third spaces, right? Where people go to the bars after work, or, and we maybe we had a parent at home that was with the kids at the park. But now, I mean, we have these limited, so many clients are talking about, I work, I come home at 5, we're starting bedtime routine by 6, with a newborn, and we're not feeling like we're getting enough time, and so it's so important to us and to invest that time. And that's not even necessarily a critique, but just noticing that we're doing that, and kind of that pressure, whether internally or socially, or even just like that drive. Like, I don't want to say this as like negative, but we are spending more time than ever before, and we still kind of feel like it's not enough. A lot of folks are coming in, saying that, feeling like it's not enough, that we want to just be with our kids all the time, right? Those positive relationships. I mentioned this kind of before, that hyper independence, hyper individualism. We are very isolated. We do things behind closed doors. We do not, have our communities like we once did. Huge contributing factor. And not only that, and again, if I kind of go back to social media, like, we've always curated our images, right? Like, if you came over to my house when I was a child, the portrait that my parents picked of our family pictures was a curated image, right? They didn't pick the one where somebody was making a goofy face. They tried to pick the best one, and they hung up on the wall. But what you also saw when you came into my home was maybe dirty dishes in the sink, or you saw the toys that my sibling had left out, or the blanket that I left, or, in my house, it was those little, in the summer, those little push pop, the tubes, right? All the little cut off tops of the tubes that we would just leave everywhere. You saw that too, right? And so when we're not, kind of doing things with as much open doors and as much a sense of community, and again, kind of going back to, a lot of folks are saying, well, if I have the choice of just my family and just being with my kids and my spouse or whatever, versus, going out and being with others in community, we're more likely to choose, well, we just want to do our own thing. Again, not necessarily, I don't want to say for, kind of for better or for worse, right? But it has an impact. Obviously, things like lack of paid leave, high cost of childcare, just are really impacting, just like family decisions, even just family planning, and how, we're doing all of these things. So just kind of some of these challenges and pressures. Like I said, dual income families, which then definitely leads to household division of labor. And even in families where, marriages where they would say that they're egalitarian, studies are showing that, women are still doing a major of the household labor and the childcare labor, significantly. So let's see. Yeah, the study that I wrote down here was that we spend twice as much time as moms did in the 1960s with our families. Double.
That is so interesting to hear,
Yeah,
because I wouldn't have guessed that either,
yeah.
right? Like, in my brain, right? It's again, maybe it is the parental guilt, right? It's like, oh, we're not spending as much time with our kids, and then thinking about, how you've explained, like, we're spending more time with them and we're working more.
Yeah.
It can't be
Well, and yeah, just this whole slide,
right?
it's just cue formula for burnout, right? Like, yeah, just overwhelmed and burnt out. And none of this is even throwing in people going through a pandemic and what that brought on. Like, where there is, I very much believe we are absolutely still kind of in the coming out of that and in the recovery. And what does that even look like? That's not even really on here. But yeah, no, it is quite surprising. And again, how many of the folks that I see still feel like it's not enough, right? And there's that social comparison to generations past. Well, my mother and my grandmothers.
Yes. And even more reason for why this conversation and this training today is so important, right? Because when we think about it, especially in that context, it's like, yes, of course, right? These individuals are going to need support and understanding that.
Yeah.
So.
Yeah. 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 And yeah, kind of to that final point here, like, yeah, this, the social construction of motherhood, which I think we've kind of been getting on a lot here, but when the studies show that most moms believe that they are doing a worse job than generations past. So like we talked about on previously, like that guilt and that shame, and again, the grandmothers and my mother, it wasn't this hard for them. And the thing is, like, they weren't parenting under these conditions in these ways. And so all the ways it kind of, you can't make that comparison because we can never kind of really prove that or not, but it's the fact that we believe that we are doing worse, and how that impacts us. But yeah, also a lot of times I'll work with folks around, because I hear this all the time: good mom, right? What does it mean to be a good mom? And again, like, the stakes could not be higher. We care a great deal about that. And yes, we want a society of children that were raised by parents that felt capable and healthy and well to raise, well-adjusted, healthy, happy children, right? Authentic selves. And so where do we get our ideas of what is motherhood? What does it mean to be a good mom? What are the things that I'm telling myself? And it's hard, but I feel like I do spend a lot of time, and I'm putting this more bluntly than I would to clients, but I feel like I spend a lot of time being like, whoa, you got to lower the bar. Like, you have put the bar up in the sky, and I love it. And that is beautiful, but like, woo, the good enough bar, right? Winnicott, the good enough parenting, the good enough mother is like here. And again, I'm saying that kind of bluntly right now, but kind of helping people reality and expectations and navigating that. Cause like, they're like, you're telling me to like give up on being this kind of a mom and just be okay being this level of a mom. And I'm like, yeah, like a little bit. So again, could get into that more, and I'm happy to address questions, but I hope that what I'm talking about there comes across. So okay, so a little bit more just about, yeah, like kind of how do we meet folks here? How do we meet folks in this space? So these are not, I'm not kind of talking like use this, apply CBT in this way, but I'm kind of giving you some ideas for understanding kind of like more of like high level, like kind of some concepts, and hoping that this can help you in your practices make that work for you. Here's this cliche, right? The butterfly, but I think it's so helpful. This idea of like that it is a transformation, it is a process, it is a metamorphosis, right? It is not just the growing of an appendage. And that takes time. It takes time to adjust to these new roles and identities, that ever evolving, that process, evolution, that type of language, and sometimes I'll do that with folks, are you trying to compare yourself to 25-year-old you when you're 35-year-old you, and what do you think that 65-year-old you might have to say, and so sometimes some work like that. Oh yeah, I kind of mentioned this, right? That like, you're not going to ask that 13-year-old when you're getting back to them. We recognize that transition. One of the things that I think is so important is that like when a butterfly even like emerges from the chrysalis, like it does not just take off and fly. If you've ever watched this, like we said in the introduction, I was at Iowa State for 13 years as teaching faculty, and we have Ryman Gardens up there, and we have a butterfly garden. And so you can go and you can watch them hatching, and they hang out on those little chrysalis. The chrysalis kind of opens, and then they're just this smushed up little thing, and then the wings. It takes days for those butterflies to like kind of fully come out of that, and then they kind of, and then the wings come out, and then they kind of move the wings, and then they sun them, and then they dry them, and then they start flying. And I think like, again, using that little cliche, but helping with some of that imagery and metaphor of like, again, this is not this overnight thing of like, oh, you just had a baby, boom, transition done, no more than it was the same in puberty or the teenage years, adolescence. And again, where I think that the language is so important, where I think that we can meet folks here to again, provide some of that psychoeducation, to normalize, validate, hold space for that, in that transition. I shared this on the podcast, but this is one of my favorite stories about this, they call it caterpillar soup in this study that I read. And I'm so sorry, I do not have that citation in front of me, but I can't remember. It's a good, probably 10-year-old study. But the idea when you talk to people about like, you're not you anymore, and you're transforming. And again, right, we're talking about loss, we're talking about grief, but like, I liked all the things that I did to become me. I had achieved, and again, like the 18-year-old is not the same as that 13-year-old, but they're still them, And so I do think that that's a helpful way to look at it too. But with the caterpillar soup is this, what they did is a study, and I think that they trained caterpillars to like recognize a scent. Don't ask me how they did this, not a biology major, right? But they trained caterpillars to recognize a scent. And then they found out that after they had become butterflies, they retained that memory of the scent as butterflies. And now, why is that a big deal? Because while it kind of looks like it, what happens in that cocoon is not just a caterpillar grows rings. What happens in that cocoon, and again, I love this metaphor, is that caterpillar turns to soup. That is what they called it in the study. Like, this caterpillar comes completely undone, and they are soup, they are mush, caterpillar soup. And then they turn into a butterfly. And it gives me goosebumps to just like think about that, like how in our own lives and through these transitions, whether that is parenthood or other huge life transitions, when have we come undone? And again, it's dark in there. I'm soup, and we come back together as something new and different, and we remember, right? Like the butterfly remembers. And so I do think that's helpful, again, in whatever context you might want to choose to use that. So, like I said, I think a lot of things I probably built into some of these other slides, but just to hit on these again, so much the power of therapy we know is the making space and the holding space, right? And it is that relationship that we develop with that client so much more than any technique that we are applying, in my opinion. And we can all do that, whether you've done tons and tons of perinatal training or not, but to say, I see you, I hear you, hey, what you were going through is totally normal. And that's hard, and hard is okay. And we can show up in this space, and it's okay to be sad, and it's okay to grieve, and it's okay to be mad about the things that you can't do right now, whatever that grief looks like, right? We can provide language. We can provide that psychoeducation. We can listen and bear witness, right? Just letting people tell their stories. And a lot of times, I've often thought, when we do postpartum care, medical care, right? And we have the one kind of big appointment for mom. I feel like if we just even had people have a required like 3 sessions with a mental health provider with some training that just does even just listening sessions, that is just like, because again, after you have a baby, everything is about the baby. Again, why the title of the book, You Matter, how you are doing matters too. And that ability to just like tell your stories, talk about how you are feeling, whether that is from the birth trauma, whether that is from the like, oh my God, what have I done? And like, I really, really, really love my baby, but oh my God, this is so hard. And I think I've completely screwed up my life. To be able to sit in a safe space and do that, we can do that. We can listen and we can bear witness. And just that, even I think people getting 3 sessions of even just kind of like listening sessions where we didn't necessarily apply anything other than like empathetic, reflective listening could do so much for our perinatal society. Obviously, like building awareness, like doing trainings like this, understanding kind of some of the clinical presentations, understanding some of what is just kind of common and expected, and meeting the people there. Screening, one of the most common screenings that most folks use is the Edinburgh. They have one that is, I think they even have one that's a 3-question scale, but 9, I think the full one is 9. And it doesn't do super well with anxiety. I mean, again, like a lot of things, I think that they're kind of revising and I'm expecting more things. So just kind of be aware that if you're going to use this key one, that might not be the best. If you're more suspecting anxiety, it really just might be better to use like an anxiety screener. And then again, just connect, right? It's just like, it's that meeting them in that space, meeting them in the messy space, and your stuff that you're telling me isn't scaring me, right? Like I can hear that, I can be there with that. And so kind of, again, those relationships, that rapport, that again, the power of like, I see you, like I hear you is huge. And a lot of times too, I do think through perinatal, and I think that this is our work as clinicians in general, but especially in perinatal, sometimes there's definitely, right? Like we're mothering the mothers in a little bit. And I hope that doesn't sound like, I hope that is interpreted as I kind of intended, as not overstepping, but what is that? We don't, not everybody had that really warm mothering person. And so often people are talking about how they need that mom and we don't have the communities and blah, blah. So that little bit of like how are we showing up in that space, in this microcosm of kind of modeling some of that I just think comes out. So yeah, personally with rapport, in that way when they're in our offices, and then obviously with like local resources and things like that as needed. Helping folks with the mourning and grief, I really do. I think that this is a big one, that where we do kind of have to name that and kind of maybe help folks with that. Yeah, I think hit on all that. Yeah, it's so normal to have the mixed emotions. So using the and instead of the but, teach that one a lot. Again, it's just kind of that core technique. I really love my baby. This is so exciting. I wanted this baby so much. I'm so glad that they are here. And oh my God, this feels kind of awful, rather than, but everybody's okay. So that's all that matters, right? So let me silence myself. Let me invalidate myself. Let me shut that down. And when we use the and, right, as I'm sure so many of you know and use, it makes space for both of those things, right? They're not mutually exclusive. And the but kind of does that. So a lot of times I'll catch people be like, let's not self-gaslight. Let's leave space for both of those things, all of those things. Let's see, anything else? I'm going to talk a little bit more about self-care on like my next slide too, but these are things that can be definitely helpful. Developing a self-care routine, of course, if nothing else, even just calling it a routine. I have just take personal beef with the term self-care a little bit in the way that it's used in our culture. Again, it's often a source of like guilt. It's often a source of like, cool. You think I'm just leaving free time on the table and I'm choosing not to take care of myself? So caution with how you talk about self-care. It can be surprisingly triggering with this population, right? Or any of us, but obviously, again, I'm saying all of these things not because they're easy, but building a support system, seeking out professional support. We talked about that cognitive dissonance, right? That clash between kind of expectations and reality and the way I'm feeling about things versus what society is kind of telling me. Recognize those losses and the gains, again, kind of using that and I caution against that toxic positivity, right? Like you're healthy, baby's healthy, like, and there's still a lot of hard here that I want to talk about, and again, I'm thinking all of you are probably great clinicians that would never do that, but sometimes it happens. So we'll just say it. Self-compassion. Oh my gosh. Right. Like we are so harsh on ourselves. And if you are working with any of this population, usually, I mean, you can just hear it, right? Like the not good enough. I was wrong. I got upset. I was grouchy. I would, just so hard on ourselves. So helping people dial up that self-compassion, kind of radical acceptance, some exercises like that can help. Again, ways that we're going to explore maternal identity, just like we might do, identity exploration in other ways with other populations as well. And like I mentioned earlier, we're definitely kind of some solution focus often at the get-go, kind of depending on how somebody's coming in or why they're coming in, but a lot of times, so kind of be prepared for that. So I wanted to talk about self-care just a little bit to expand the different types of, and honestly, we could add a 6, which would be kind of like professionally. It just didn't fit on my slide, to be honest. And I was like, man, that's the one I can drop off for this conversation. But right, so looking at self-care with so much more of like an expanded approach, right? And recognizing like we have got to validate people in the challenges for time. I mean, so I do say this conversation is important and I want all of you to be having it. And also, I just want to give you the caution about how we talk about it. With anyone with kind of young kids in the home at all, even if you're directly in the perinatal. But like I said, go back to those slides, right? Challenges of the modern parenting, recipe for burnout, So yeah, psychological, what are the ways that we can engage in psychological self-care, physical self-care, emotional self-care. I love laughing and crying. Right? How can we name that as self-care? And sometimes I will be like, put on the stand-up comedy if that's what it takes you to like get some of those kind of those good endorphins or things like that going. Yeah, spiritual, many different ways we can look at that. It's not just going to church. I love, again, saying singing and dancing, moving that body, singing. I know that there's been some studies too about the way that like exercising those vocal cords and putting stuff up is very good too. And then just personally, different ways that we can do all of that too. So not just go take a bath. And I always tell folks too, I'm like, listen, go take a bath. But what we're not going to do is attach this idea that the bath is going to fix what's hard on the other side of that door. Right. And that still doesn't mean go take the bath. And let's be realistic and let's manage all of that. So I think I got some resources here. Project Teach was one I kind of wanted to draw attention to, a great source for consult. And yeah, Postpartum Support International, where you can find other providers in Iowa, in your local communities. We have an Iowa chapter. They host events annually. One of them is called Climb Out of the Darkness. That's an awareness event about PMADs and, so climbing out of the darkness of being in those challenges, awareness and kind of fundraising. They do even, legislative action and things like that. So they are a great resource as well. Speak the Secret, Postpartum Stress Center. I had mentioned before Karen Kleinman. She's the founder of Postpartum Stress Center. She's written several books, and one of them was the one I mentioned, Good Moms Have Scary Thoughts. And Speak the Secret is folks sharing those. So again, knowing you are not alone. And you got to be very cautious. You're probably not going to want to be like, see, go and read all of these that all these other people, use with caution. Maybe check out that resource. But for some folks, it might be helpful to see that book. I mean, I have a copy of that book, Good Moms Have Scary Thoughts. Be like, listen, it's a book for a reason. It's a good selling book. Yeah. Questions, thoughts, additions.
Yeah. This has been so incredibly helpful, right? In thinking about, postpartum and beyond. And one of the things you said when we first started is people's maybe just unintentional mislabeling, right, of postpartum and kind of going, yeah, I experienced postpartum. And even my room was like, oh yeah, like when you said, of course you did. Everybody experiences postpartum, right? Postpartum what? And it's like, how are we kind of referring to that time period and being able to have those conversations with our clients and recognizing what is kind of in that 3 to 4 month transitional foggy period and what may be extending and surpassing that and having a toolbox for when are we reaching out to you and your agency, right? And or other specialists in that area. And I loved, Amanda, how you touched on that just recognizing the hard, right, is valid. And for clients who aren't meeting diagnostic criteria, above and beyond an adjustment disorder, that is valid, right? And that experience is valid. And however they came into parenthood is valid, right? And being able to explore that. I think one of the other things you said that has really just stuck with me this morning is when you talked about it's not just a new title, right? It's a new self, and going, yeah, right. Like I'm a parent now, but what does all that come with, right? And so much incredible and helpful information. I
think I talked about that on the podcast that, when you ask people, if you're just asking somebody out in the world, right? Like not even a client or whatever, like, are you feeling ready for baby to come? They're kind of towards the end of pregnancy, and almost unanimously, they will say, the nursery, and I think that is important, not in some type of joke. I'm not laughing at people or anything, but like the way that, again, we conceptualize so much of like, well, we just need a place for baby, right? And I have carved out a place, and it is called this nursery, and I have the stuff and the things. So again, it's the add-on, it's the extended package on my life, and it will just fit over here. And I get why we would think that. And I think almost probably all of us probably thought that if we're parents at some point. And then to find how much that is not the case.
Thinking about that, right? I love kind of highlighting that, because thinking about that in relation to all of the other things that you've shared with us today, right? And okay, I've carved out this space, right? But really this baby that is making their way into my life is changing all of who I am, But I also now have these societal norms to keep up with that say I should just figure out where it goes. And, I'm guilty of it myself of, talking to expecting parents and being like, you don't know what you're in for, right? But like, I'm not going to do anything about that, right? I'm just going to kind of laugh and humor you that you've got to figure it out like we did, right? It's like, like we can do so much more.
It's interesting, like with, just my work and then like the book, especially too, like folks will say, is this for a pregnant audience? Because so many of us, like as clinicians that know this, right? We know these risk factors for PMADs. And again, PMADs aside, just the challenges that are coming. And we say, like, how can we get to them? And I have been doing this for many years. I don't know what's the math, but many, many years. And I have found, and I do not mean this disrespectfully, I have found that like pregnant, especially first pregnant, first baby, cannot hear it. Like, I think that unfortunately it feels, I'm imagining, this is kind of my hypothesis and theory, like it feels too threatening to hear. And we didn't even talk about this here, but like how much the impact that this has on your relationship with your partner, right? Like, there's a book called How Not to Hate Your Husband After You Have Kids. And again, I'm like, there's a book named that is a bestseller for a reason, because again, that is a very, very common experience. And when you are sitting there with that significant other, with that partner, where this baby is a manifestation of your love in physical form, and somebody tells you, you are going to want to, pop that person in the middle of the night for not being able to take care of the baby because they're not nursing. I can't hear you telling me that, right? Like not us, not me. And I think denial is a defense mechanism, or kind of, again, like I think that this information of just how hard it is going to be feels very threatening. And I think people are very unintentionally, right? Very like those automatic kind of defense mechanisms and shut down to this information, and again, so most people are like, even if I had that day in my childbirth ed class where we got some of this, I didn't hear it, right? Like I didn't get it until I was doing it. And I think that that's a little bit unfortunate. Like in my role here, I'd love to do more education, more prevention. And there's a little bit of me that's just like the mind kind of won't let us go there or we just can't process it. So anyway, a little bit of a side note there, but yeah.
No, so critical, right? Of like those defense mechanisms are up, and we talked today too about the perception, right, that maybe others want to put into the world of how well they're doing, right? So not only can I not conceptualize that I may struggle, those around me may kind of touch on it, but very few are probably really letting me into that proverbial messy house, right?
Yes.
And seeing what's happening. And I couldn't help but think about sort of that analogy as you were sharing today as well, right? And thinking about where we've come as a society of I'm cleaning, my house for 95% of people that are coming over. And maybe I have a couple that it's like, that's fine. You can come in when there's toys on the floor. And as a provider with parents, right, thinking about how do I create that safe space for them to share their mess with me, right, and to talk about what's happening. And so I think all of the tips and tricks and information you have shared today has been so helpful. And for those that are watching this recording later, if you haven't listened to the podcast, go listen to the podcast. There's some great tidbits there as well. But they can find you at themeadowlarkclinic.com. We'll put that in all of the show notes. And so whether they need to talk about making some referrals or getting some additional information, I know you do all sorts of trainings and presentations. You've got a busy week this week presenting again. It is May of 24 right now, but doing another presentation in Des Moines today about how the village isn't coming, right? And talking about some other parenthood transitions, right, of support. And so again, all of what you have shared will be in our show notes. I cannot thank you enough for the knowledge that you have brought with you today and have been willing to share with all of us. So Amanda, thank you one more time for joining us on you need a training, and we appreciate having you here.
Such a pleasure. Thank you so much.
Thank you for joining in on today's training. We look forward to having you join us again. Heart & Solutions is proud to provide CE-eligible trainings for our counseling community. This training may be eligible for continuing education credit hours through either the National Board for Certified Counselors, provider number 7376, or the Association of Play Therapy, provider number 21-645. To obtain CE hours for today's training, be sure to follow the steps in the description below.